part of the concept is that prostatitis, is this really a diagnosis, or is it a diagnosis of exclusion? Because just what is your method as a physical therapist expert in male pelvic
What
dysfunction?
the hell is prostatitis? So if you break it up, it's inflammation of the prostate. Now, we do know that acute prostatitis is a thing in men.
Welcome back to the Dr. Gio Prostate Podcast. A lot of men are told they have prostatitis, but what if that diagnosis is incomplete? What if the real problem is pelvic floor dysfunction? In this episode, Dr. Gio speaks with Dr. Adam Gvili, a pelvic floor specialist who is helping men finally understand the pain, tension, urinary issues, and sexual symptoms that often get missed or misunderstood. This is a powerful conversation about what is really happening in the male pelvis, why so many men struggle in silence, and what healing can actually look like. If you've been searching for answers, this episode may change the way you think about pelvic pain. Let's get into it.
Before I proceed, I just want to clarify that this podcast and all Dr. Gio content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Welcome to the Dr. Gio Prostate Podcast. I am Dr. Gio, your host. Today, I have the pleasure of speaking with Dr. Adam Gvili, who is a pelvic floor specialist. How do you treat pelvic floor dysfunction? Men, right? Men with prostatitis. Is prostatitis a real thing? You might have heard with my previous conversation with Jeanette Potts, expert in the field. There are not too many experts in the field, but we have one today. Adam, thank you. Thank you so much for being on.
Thank you for having me. Thank you for shining a light on such a much needed topic. Honestly, I'm so happy to have more of these conversations as the months go by. So
Good.
Really, you're doing God's work.
Thank you so much. So are you. And I have to ask you a very basic question. What got you? Most people, I've chosen the road less traveled, right? So with my naturopathic and functional medicine, I want to focus on prostate problems and urological problems. Road less traveled. You become a physical therapist, you get a doctorate degree in it, and you choose pelvic floor, primarily male pelvic floor dysfunction. What got you into choosing this particular field?
So it's a great question. I myself went through a pelvic floor dysfunction for about 6 years. Prior to that, actually, when I was in physical therapy school, what I would notice is pelvic floor classes was almost not a thing. We did one day's worth of pelvic floor coursework. That was probably one Saturday where we did both genders, both male and female. As we know, there's so much extensive knowledge that goes into this field, and one day we'll definitely not cover it. So it's a lot of postdoctorate work, a lot of postdoctorate learning. Given where this field is, we're constantly learning new things. But I myself got an interest in it because I went through what it was trying to find a viable practitioner. So going from the urologist's office, other primary care physicians, finally the only thing that actually worked was pelvic floor therapist. And it took 4 pelvic floor therapists until the last one actually helped me.
Wow. And so then what's the training? So there's no training within your curriculum to get your degree. So what kind of training did you pursue afterwards?
Yeah. As a doctorate of physical therapy, you can take courses with Herman and Wallace and different certifications that are out there. But what I found is a lot of them teach theory, and it's very hard to teach good clinical hands-on skills. And most of the time, that's where the translation kind of gets lost from theory to clinical hands-on skills. We developed our own method to treatment after learning as much as we can. Most of my mentors are pelvic floor practitioners, actually not even from the US. So Bill Taylor, Gerard Green.
Where are they from? Is UK?
One at Scotland, UK, and then of course the great Joanne Milios,
Right.
all the way down under. So yeah, we try and learn as much as we can and apply it to our patients and try and gather as much as objective data as we can. But a lot of what we do is subjective. We go based off our patients and through trial and error.
There's a female expert out of the UK. I have their book, but I don't want to get up and get it. From back in the day, and I say back in the day, 20, 30 years, and I'm drawing a blank, written many papers around pelvic floor dysfunction. Would you know who that is off the top? I'll probably remember before we end.
I'm drawing a blank.
So no experts other than you now in the US, relatively speaking. Did you have to travel to get your knowledge? Did you have to go to conferences out there in Are there pelvic floor specific conferences for you guys?
First of all, I'm definitely not the only specialist or expert. There are many people. Even then, I consult with them and we go back and forth on certain patients that we might have a hard time getting better. But yeah, there are many conferences, the Ishwish conference, the pelvic pain conference. There are other conferences that other pelvic floor practitioners created themselves to gather some form of community. There's many things out there. Yeah, for sure.
Part of the concept is that prostatitis, is this really a diagnosis, or is it a diagnosis of exclusion because just there's nothing else that we can find? Sometimes you blame the organ you have. So if women have pelvic floor dysfunction, they don't have a prostate, so they don't have prostatitis. They may have interstitial cystitis. So is the man having interstitial cystitis, which is like an inflammatory situation in the bladder? Rather, what's your or does it matter? Does it matter? What is your method as a physical therapist, expert in male pelvic dysfunction? What is your method of assessing what's going on? What's the root cause?
So that's a loaded question. So let's start. Chronic abacterial prostatitis is, as we know, probably 95 to 98% of the cases that most men will come in with, correct?
Yeah.
There's an absence of bacteria. You won't find it in the urine in most cases, even when doing semen analysis or semen culture, yeah? Sometimes you'll find like Enterococcus faecalis or these weird bacteria. And most research actually states that some of this bacteria is actually quite normal to be there. So then what the hell is prostatitis? So if you break it up, it's inflammation of the prostate. Now, we do know that acute prostatitis is a thing in men from ages, let's say, I'm going to use an arbitrary age, but let's say 20 and above, it happens. But acute prostatitis is usually accompanied by systemic symptoms, which is systemic. You have fever and malaise and certain other things that would indicate an infection. We don't see this when our chronic abacterial prostatitis patients.
So the guys you and I see probably, and that's 95%, it's probably non-bacterial, right? And no fever, and just they feel off in their pelvic area.
Correct. And if I will say, I missed one of these cases in the last, I've been treating for 8 years now. I missed one of these cases and it was my fault and it was a learning.
I'll share my story after you share yours.
So I'll tell you. So I had this one guy came in and he told me he's been to 2 or 3 urologists in the past week with the same symptoms. Now, mind you, this guy sits down. He's like having a hard time sitting down. Not crazy for some of the patients that we've seen with pudendal neuralgia, procticalgia fugax, right? They have pain sitting. So as I'm assessing him, he tells me he feels really weak. He feels off. And I tell him, look, I have a urologist. I really think you should go check him out. And he goes, no, I already checked out. I got this checked out. Everything's fine. After 2 sessions, we didn't get him better. I saw him twice that week. Usually we do have some decrease in symptoms. Nothing. I was like, please just go get yourself checked out. It ended up being a bacterial infection, but none of the urologists actually screened for it. And we found this out from urine culture. So that was the one time I missed it, and it'll never happen again. Of course, if he came in without being sick.
Did that patient present with fever or feverish type symptoms?
So feverish type symptoms. He told me he felt warm. He told me that he had a fever the night before, but he thought that maybe it was flu symptoms. Something didn't add up, but he wanted to be treated. And I was like, okay, let's see where we go with this. So it was around 3 days after that I was like, I wouldn't have you come in next week. I would actually have you go see another urologist or perhaps go into the emergency department just to check. And that's what it was. So I will say, if he wasn't seen by a physician, there's no way I would have seen this patient until he was screened. But he was already seen by 2 or 3 practitioners prior to seeing me. Again, that was my mistake. If I go back to prostatitis, inflammation of the prostate, sometimes I question on whether urologists just they have to bill in order to get paid for the services rendered, correct? Sure. And how could they do that without a diagnosis? No insurance is going to pay unless you let them know what's happening or there's a reason to treat them. So inflammation of the prostate just sounds like, to me, kind of like telling someone they have sciatica. Sciatica is a diagnosis telling us something is shooting down your butt, your leg, ridiculous symptoms, correct? But we don't know if it's coming from your spine. We don't know if it's coming from your piriformis, hamstring syndrome. We don't know any of that. So it's like this broad thing that's telling us something's going on in the area. And I feel like that's what prostatitis is doing, except it's incredibly misleading. It's incredibly misleading to the guys that are in ages probably 45 to 60.
Correct.
Majority of the men that we treat are 25 to 40. But a guy that comes in that's 50 years old and gets a diagnosis of prostatitis, he just assumes that A, he has BPH, and he's screwed for the next 20, 30 years of his remaining years, whatever it may be, because his prostate health is not good, which is not true at all. That's what I'll say about that.
Tell me what you really mean now, Adam. No.
Tell me what you mean.
A case that I saw, this was like a 32-year-old man who comes in and he's presenting with symptoms that was certainly in my mind prostatitis, almost textbook, non-bacterial. So pelvic pain, lower abdominal pain, sometimes around his transperineal area. That's the area for the audience between the scrotum and the anus. But when he urinates, it's a little bit painful, discomfortable. He said he had these symptoms. He started in college, but they were mild and it just got progressively worse. Physical exam can be tricky. I don't know. We'll talk about that. I don't know that we really know if we feel something, yeah, that's prostatitis. If we don't, that's not. I don't think there's a lot from a physical exam. So then anyway, so try this protocol. I have many protocols for prostatitis. He tries a protocol that included a couple of dietary supplements, natural anti-inflammatories, and so forth. He calls the office. He says, look, you got a call from a patient. He's doing really poorly. I call him. He says, look, I'm crying. I'm actually, my son, my 4-year-old son is listening to me cry because I'm having a really difficult time peeing. I said, this is definitely prostatitis. Maybe you're not taking enough of the recommendation, curcumin and other things. Double up. That's a lot of, and maybe you're going to need an actual NSAID. He did it, didn't improve. Bottom line, I said, see my colleague, Dr. Brucker. She's Dr. Brucker. He had a urinary stricture, right? Urinary stricture that got probably from the time he was in college, that got worse and that caused all the symptoms. Literally surgically removed the urinary stricture. And I saw him, this was like 10 years ago. I saw him not that long ago. He's like, this is amazing. This was right. So I got the diagnosis wrong. And really he needed medical treatment that optimized his life. So I think it's very important. I always say, I go to sleep and I've seen thousands of patients. I see several hundred a year. And maybe 95 or so do really well, even with prostate cancer, prostatitis, or BPH. I go to bed as, what did I get wrong today? What did I get wrong? What diagnosis or situation or protocol did I not get right to optimize? This is how it is. I think I was traumatized from that experience, but this is the humbling a factor of being a clinician, right?
Yeah, it's really important. You're clearly a humble practitioner and you want to learn because you didn't make a mistake. You really just learned for the future.
Correct.
That's all it was.
Still happens.
Correct. And that's the beautiful part about being a great practitioner is that sometimes you're not going to win as much, but you won't, if you do it correctly, you're not going to make that mistake again.
Yeah. If you try to look at things objectively, and I always say we are all biased to some degree. I have my biases when people go to the surgeon. So he's asking me to tell me to do surgery. He's being so biased. Yeah. He is, or she is.
Surgeons do surgery.
Surgeons do surgery. They love what they do. They think they're the best at it. They want to do more. And I think if I was a surgeon, I probably would be the same, though I would hope that I would do the surgery to the right patient. And that's key.
Right.
I think it's very important for us to look at our biases and challenge them. And at the end, all we want to do is do right by the patient.
And that's the tricky part now in 2025 because people have lost confidence in the medical community.
Yeah, for sure.
Whether it's post-COVID and the COVID vaccine, even before that, right? We heard of doctors making money off of medication. That's what people thought was happening, right? But Stark's Law is a thing. It's not really, right? But people have lost confidence. Sometimes coming to even a provider like myself, who's $320 a session, they're like, is he trying to sell me on being here because he's the business owner? Or does he really want good for me? And so that question is constantly asked, whether you even go to a hospital-based doctor, is he just trying to get me in for another surgery so that he can make more money off me?
Yeah. Does Dr. Gvili have kids in college? Yep. Maybe that's what he's asking me to come back over and over again. Because
you start getting into some crazy scenarios.
Listen, sometimes there are true factors there. And I think that if you're doing the right thing, it doesn't matter. If you know you're doing the right thing by the patient. And again, challenging those biases that we all tend to have.
Correct.
So moving forward, we're going to talk about male pelvic dysfunction across the board. Prostatitis is one of those types of dysfunction, but it could have just male pelvic pain, prostatitis, whatever you want to call it, just male pelvic dysfunction. So this is a man who comes in and they present with pain somewhere in the pelvis, whether it's lower back that is unrelated to actual back pain. They have lower abdominal pain, perhaps between the anus and the scrotum, a lot of discomfort there. the way they describe the pain and discomfort is different, right? Sometimes there's a burning sensation. Sometimes it's like a prickling sensation. Sometimes it's just dull, achy pain in a scale of 2 to 3 out of 10. It's just like that constant headache that they call it headache in the pelvis, right?
Great book.
Great book. By the way, Gracie Dory, I was thinking about from the UK, who's written, and she has written papers on it just to talk about great books.
Yeah.
And so she's been one of the ones that I learned from back in the day. I'm a couple of years older than you. So when I started this, I started specializing, not to completely digress, which I am, about 21 years ago, after all my training, I said, I just want to do urology. And I took a deep dive and trained with physical therapists, actually, not to become your replace you, just to learn what's really happening there and how can you help. And then
Sure.
I trained with urologists in the OR for prostate cancer, BPH, and prostatitis. Not a lot of urologists actually experts in prostatitis and pelvic pain dysfunction, nor do most want to be. I'm an acupuncturist, so I learned acupuncture specifically for that. Anyway, all that to say is that there's very few experts that are out there treating these patients. So going back to the story, so this is a man, some discomfort down there, might be accompanied by urinary problems, sometimes urinary frequency and urgency, and probably affecting his sexual functioning, right? Whether it's premature ejaculation or some ED or something. What would be your process and they're talking about, by the way, this is having an effect on them mentally. It's causing anxiety and depression. They are hesitant to socialize. They're hesitant to talk to, if they are a heterosexual male or even same-sex male. They're afraid to go into relationships as a result of this because they don't know if they can even function. This is really taking a toll. And so then they still working. They're still able to go to work. They're still able to have a somewhat normal life. I say that because for some men, they can't move. They don't leave their homes. They have to, we're talking pain 9 out of 10, not 3 out of 10. But I think most patients have 3, 4, 5 out of 10.
Yeah.
They're doing their thing, but it's having a big toll. So what would be your process to helping these men?
For a patient that comes in a 9 out of 10?
No, let's keep it at 3 to 5 out of 10.
3 to 5.
And maybe we can talk about the more advanced case.
So I'm going to add to what you're saying. If we think of the picture of who this patient is, yeah, who's our avatar? It's probably most likely a male, 25 to 40, that's probably seen upwards of 3 to 4 practitioners at this point, a few urologists, primary care. Hopefully they haven't gone down the chronic pain specialist yet. And at that point, they've either tried some course of antibiotics, not fluoroquinolones, so hopefully something way better, but not a Levaquin and a Cipro. At that point,
not. I know the answer. But so these are your fluoroquinolones, Cipro, and Levaquin. And why is that an issue?
This is out of my wheelhouse, okay? I do study pharmacology as much as I can, but just because I'm an MD doesn't mean I can't comment on this, okay?
I understand.
And I know you're asking the question. I'm just letting people know, just because we're physical therapists, we understand pharmacology,
sure.
Right? Like for the vast amount of urologists that give the alpha blockers, right? And they're like, oh, enjoy. But the patients don't get better with their urinary symptoms. Why is that? Because it's not always relaxing smooth muscle that's the issue. So we have to look at it further. But they give them this arbitrary timeline of take this for 6 weeks and come back. What happens then? What do we do then?
Yeah,
right?
and in some defense for the urologist, they will tell you, I don't know what to do with these patients.
That's a great urologist.
I'm as frustrated as they are. Because I wish we knew more. So actually, you know what or at least the ones I know are offering? Supplements. We keep digressing, but we'll jump back. But it's so important. There's a few supplements just at the AUA guidelines for prostatitis that they are part of the AUA guidelines. Things like saw palmetto and quercetin are part of the AUA guidelines for prostatitis. This unheard of that.
How many milligrams of quercetin are we talking about? 500 to 1,000 or much higher than that?
500 to 1,000. More towards 1,000. Yeah. Anyway, it's there now. So they oftentimes now, before prescribing some of the antibiotics, will prescribe a supplement, which is, we've made great strides. Back to the question.
Sure.
Why not fluoroquinolones? Though you and I know the answer, but I think is a very important part of the discussion.
Yeah. Black box warning, the tendon health issues, if you have the genetic markers, which I'm not sure what they are, but if you have for the genetic markers that you might react to this antibiotic, it can really screw you up. Something called Flaccid, if you want to look it up. So
you can tear your Achilles tendon.
That's the main one, correct. And if you're a 20 to 40-year-old guy, I think there's no way in hell you should be taking these
Active,
antibiotics.
going to the gym, proudly tells you, no, I exercise. That's
Correct.
actually the guy that can fall into. And not to mention the microbiome, which is so important, we know now, and all the other, and resistance. We've said before, and we've had 3 prostatitis episodes. I think you've seen them. Almost never would I want my patient to take an antibiotic for prostatitis.
Interesting.
Almost never. The only case would be if that 5% that has an acute case. And even in those cases, sometimes we've been able to treat it naturally with natural antimicrobials. Just keep making sure that they don't get worse, develop some other worse, but almost never. Yeah.
Do you think that there's, I don't know if this even makes sense, but due to the proximity of the prostate or it's in the rectum, do you think that sometimes we get something like a leaky prostate or a leaky gut where, yes, there's an impermeable membrane, but are some parts of it permeable? And that's why we get stuff like Enterococcus faecalis, or I'm just asking.
Yeah, I do. I think so, but that's theoretical. Really appreciate the gut bladder connection. There is connected neurologically, comes from the same stem, right?
Sure.
So there's a stress factor there and so forth. But I really do think they are tight. The gut and the bladder are tightly connected. And so, yes, I think there's might be some transfer there going on from leaky gut or leaky colon or leaky whatever. So gut health, this is your interview, me interviewing you. But I think gut health is absolutely imperative for pelvic health in men. I think they're connected. Yeah. The gut process, prostate axis, we call it.
Okay. So we'll have to interview you on that one.
I can't wait.
So if we go back to your question, the gentleman comes in 3 to 4 out of 10 pain. Been dealing with this for quite some time. At this point, he's seen multiple practitioners. Hopefully took some okay antibiotics. We also know that antibiotics have an anti-inflammatory effect. So they might even tell you like, hey, I felt better on it. It works
for
like
a week or two. Yeah, good point.
A week or two.
Good point.
Yeah. So for pelvic floor practitioners, note that. And then from there, validating their symptoms. At this point, because they've seen so many practitioners, from the patient standpoint, they've sat in front of someone, they've tried to corroborate all this information from practitioner to practitioner because they have to be their own advocate. And then make sure that they're presenting this all and package it nicely so that this person understands not only what they're going through, but what that means for them in the future. That's a lot to unpack. And then sometimes they see these doctors or other practitioners and they're like very dismissive. They're like, you're fine. Or the worst thing is that they say it's anxiety. Now, I don't know about you, but you're a guy. But if anything's going on with this region of my body, that's going to make me pretty anxious.
Yeah, correct.
Especially if I've been going through something for X amount of time and no one's been able to figure out what the hell's going on. It's going to make me anxious.
And the translation, Adam, for the patient is this is in your head.
Yeah.
That's the worst thing you could tell these guys. Now, to be frank, I would love to know what your thoughts are. If I'm dealing with this for years, after a while, there is a psychological element for sure. But this is not created by me in my head. This is something physical, right? That's now having a mental and psychological effect on me.
Yeah. Yeah. And so at this point, I want to validate the patient's symptoms.
Yeah.
I also want to change the language. And I'm not telling them, hey, you were diagnosed prostatitis. That's bullshit. That's not a good diagnosis. Don't listen to them. I want to bring everything he's heard and make sense of it for him, not dismiss it. So you don't have a pelvic floor dysfunction. You have a pelvic floor issue right now. And all it is, and I tell them, is in most cases, it's a hypertonic pelvic floor, which also sounds like a crazy word, but hypertonic just means the increased state of tone in an area. And the increased state of tone doesn't allow for things to relax when we need them to relax. And it doesn't allow for what's called, this is what I explained, length tension. It's a physics concept, yeah? In order for a muscle to work well, we need proper length tension. And if you're on any other side of the spectrum, you won't be able to produce force with that muscle. Very simple. And tight muscles inhibit blood flow. Tight muscles, they allow for more lactic acid because they're constantly working. And so just letting them know, let's decrease some of this response to what's going on. Okay. And from there, letting them know that there is a way out and that we've treated many men up until this point. And don't worry, let me do all the hard work. I'm going to give you some stuff to do at home and let's start from there. And from there, we get them on the table. We'll do a series of nerve testing, manual muscle testing. I'll look into the tone of their lower abdominals. I'll look at the suprapubic region. I'll look at the pudendal region, see what the bulbo and ischial are doing, how they're contracting, how they're relaxing. And then, of course, I'll do an internal to see what does his sphincter feel like.
What do you mean by an internal? Let's break that down.
Digital rectal exam, except I'm not feeling your prostate. I'm feeling in and around the muscles in your rectum. I want to see, can you relax? Can you elongate your muscles? Can you contract? So remember, length tension is really important. So I have people that could contract, but if you can't discern the difference between a 5 out of 10 contraction and a 10, you're going to miss this, right? I want to take you from a 0 relaxation to a 10 contraction, right? And if we can only go from 3 to 6, that means you can contract to a 6, but relax to a 3, then we got work to do. And that's that neuro retraining that we're going to do. But as a pelvic floor therapist, my goal is to teach the body and brain how to tap into relaxing. And at that point, once we get you to do that, we're smooth sailing, because at that point, your body knows how to do that. And it goes, oh, I like that. How do I keep it that way? And that's all we're doing.
Tell me about the process. In to transparency, I have not done a digital rectal exam since COVID. And here's why.
DRE.
Have not done one since COVID, mostly because I don't find that it's that useful anymore.
Sure.
For anything, including prostate cancer, but that's a different story. With prostatitis, I did a lot of it just to see and look for trigger points and things like that. So my question is, that's not to say that it's not necessary. Clearly you do it. So as you're going in, what is that process like?
Great question.
Again, not a physical therapist. So,
great question.
Actually, let me say this, because I want you to break down my process when I used to do it and say, Gio, you're crazy. You did it horribly. And that's okay if you do that. Used to work my way in right from the sphincter, from the opening, and work my way in and go around looking for trigger points based on my knowledge of what that felt like, and then see the patient's response. No one loves a finger up their butts, but they'll say, oh, this is pain. Oh, and then we'll see what that feels like. And then the prostate itself, as I work my way through the prostate, around the prostate, again, no one is happy, but sometimes they jump off the table. And to me, that means that there's hypertonicity, as you would describe, or just tightness. Call them in. I'd rarely curse them, but I call them tight asses. And they laugh because like, yep.
Anal retention is a concept that we've heard from psychology, not even from colorectal.
There you go. Okay.
You know what I mean? So just to throw that out there.
Yeah.
Okay. My problem with the digital rectal exam when you go to a urologist is you're usually better. So let's go through this. You're usually better. You're looking away or the opposite direction of the urologist, or looking with the urologist, but you can't see what's going on behind you. And then you're like, whoa. And most of them aren't taught to like, take it easy, let you relax into it. At the end of the day, that's not a common practice for most men. Even if you do all the anal play and all that, that's still not a setting that would make sense for your brain and body to be like, okay, I'm good with this.
Adam, I want to say that they lay on their side and with knees way up high. And it's almost like what chiropractors do, a side adjustment. And that's the way I did it. Because that's a great.
When they did it on me, that's the multiple ways that was done, I think. But either way, I think they could be a little more gentle with it. That's all it is. Okay. Even for my pelvic floor therapists, I teach them the goal is to teach the brain and body how to tone down, to get more into parasympathetic tone. So I have to give you some graded exposure. My finger is just a stimulus that I want you to practice being okay with. And at some point, once we get that area to relax, your body really feels that. Okay, so the patient, what does a pelvic floor exam look like? Is that what we want to get to?
Yeah. What's that experience like relative to what I used to do, and how is yours different? So side patient, work my way in, look for trigger points and hypertonicity. What's your approach like?
Awesome. So if we're just strictly talking about the digital rectal exam, the patient is hook lying on the table. So that's on their back with their feet bent. They're not on stirrups or anything. It's just a flat table. And I'm going to go directly between their legs and go straight into their anal opening. And at this point, I'm letting them know what I'm doing. Okay, I'm going to do the internal now. It's one finger in the rectum. If at any point you're not comfortable, you let us know, although you should feel comfortable.
You should feel comfortable or uncomfortable?
You should feel comfortable.
Oh, okay.
I make sure to use a lot of warm lubricant so that there's no friction, especially with those with colorectal issues like fissures and hemorrhoids. And so as I go in, you're going to go through that external anal sphincter and then pass through that little canal there and then through that internal anal sphincter, and then you're in. And at some point, I'm just getting them to focus on their breath, not focusing on what's going on below. For some men, that's harder. For some men, that's easier. And then at some point, we get into the black hole that is your rectum, this empty space, so to speak. And from there, right away, that first visit, I consider it treatment, but we're not looking for trigger points right away. I'm just looking to see, like, can you maintain the contraction? Can you relax to a certain point that I think would tell myself that it's closer to zero? And then from there, we tailor the treatment for the next subsequent sessions.
And so what?
And why is that?
Yeah, go ahead.
Because it's the first time I'm seeing you and I have my finger up your ass. So essentially, you're going to get a false positive in most cases, okay? You might get some that could relax. You might get ones that don't know how to do that. But this is the first time I'm seeing you. So I do think you got to give the person a little grace.
Gotcha. As you go in, if you do find trigger points, and what would be the difference between a trigger point and just hypertonicity? What are they feeling? What are you feeling? And what would you do about it?
I would be careful to say that people could necessarily tell the difference. I think that a lot of pelvic floor therapists are going to hate me for this, but trigger point, you might feel a taut band in the muscle. I think trigger points and digital rectal exams for prostates, you're going to get inter-rater and intra-rater reliability is going to be really low. I do think so. And who's to say that the size of the finger or the length of the finger didn't change how that muscle responds? Who's to grade how much pressure that one practitioner put versus another? But I guess some say trigger points are a taut band in the muscle. You might find some nodule there that you might be able to feel. But hypertonicity is pretty cool because I think, do I feel that these muscles are almost at a tonic contraction that can't let go? And then I would label that from the 5 to 10 in my head based off the men that I've seen. So it's not really objective, but it's purely subjective. What do you think about the trigger point thing?
This early in my career, honestly, you want to sound smart, be smart. I'm a non-conventional doctor, so I'm like, yeah, trigger points. Yeah. Sure. And I don't know. Like, I don't know if this is now there's referred pain sometimes from a trigger point, right?
Sure.
So you press in one area, but you feel it somewhere else. That might be a trigger point. But it's different from you trying to feel a trigger point on your trap muscle versus the prostate area or the pelvic muscle area.
Sure.
So whether I knew that I felt the trigger point or not, I can't tell you, honestly. Right. And I'm very confident with what I do now. Maybe 20 years ago, I was like, oh, no, I felt the trigger point because I'm insecure. I'm this insecure doctor trying to make a name for myself. Now, I don't know. And the better question is, does it really matter whether it's a trigger point or not?
And even then, like, I get some practitioners telling me like, hey, I can tell the difference between pubococcygeus and iliococcygeus. I'm like, no, you can't. Like, how the hell did you do that?
Because for the audience, there's quite a few pelvic muscles in the pelvic area, and they're so together that you can't really isolate one from the other. Right. So this is like when I'm teaching people to do Kegel type exercises, and I said, we're trying to train the external urethral sphincter because you're not going to have your internal one after surgery. He said, how do I isolate it? It was like, you can't really isolate it. You're gonna feel when you're doing it, you're gonna feel some rectal muscles when you're squeezing. So this is that situation. So yeah, you can't really differentiate. And this is for the audience, all the different muscles. And again, some people want to maybe like sound smart and say you can. I haven't seen. So for you to say that as a physical therapist, a specialist in this area, brings me some relief actually.
I've learned a lot of theory, and what works the best is our human approach with our patients. Validating what's going on, letting them know, listen, I'm going to do everything in my power to get you better. We're going to work together. But I really do believe at the end of the day that we are teaching the patient's brain and body to tone down their nervous system, to get these muscles to work well again. And really, I don't see it any different than someone coming in post-op ACL and me teaching them how to reuse their quad. Except the difference here is nobody teaches us how to use our pelvic floors. In fact, I have 3 kids, and when you teach them how to potty train, there's just like this little toilet in the living room. And you're just like, okay, whenever you feel like you need to go, that's when you go. For some reason, that's how we teach our kids. And it's fine for now, but that's not good advice for later on. And at some point, adults take this advice and they're like, I have to time when I have to poop or pee, and I have to do the just in case. And so no one teaches us how to use this area of our body correctly. And so my job is to just tap your brain and body into that. That's it.
As a father of 3 kids myself, that alone can cause male pelvic dysfunction. That alone right there. I think I have male pelvic dysfunction. Do you have 3 kids?
Yeah.
Okay, listen, you can't get rid of your kids, nor should I suggest that you should. So let's figure that out.
Yeah.
Yeah, never a dull moment.
No, for sure not.
So you mentioned something, how to relax the nervous system. I think that is all related to the nervous system, right?
Yeah.
So whether it's acupuncture, some of the botanicals that I prescribe, some breathing exercises is all related to the nervous system. So what would you do? So a patient sees you and the goal is to relax the nervous system. How can a physical therapist specialist in male pelvic dysfunction help with that?
Okay. So at the beginning of my career, I used to tell people, just so you know, you have 2 parts to your nervous system. Your sympathetic and your parasympathetic.
Yeah, right.
And one's rest and digest. And now patients are so good at ChatGPT and Googling. Right. And by the way, for probably 4 years, I haven't been explaining it this way. But recently I told this one patient, he goes, dude, I already know. Okay. I need to relax more. And I'm like, I was thinking about this and I'm like, you're not being intentional with these words that you're using. You're just telling people you need to relax. It's what they're telling everyone nowadays. You have stiffness in your arteries because you can't relax and you need parasympathetic tone. So go meditate. And the truth is, if I just explain to these patients what's happening, right, from, again, a human level, as opposed to telling them I'm the doctor, you just take this, go away, or give you some weird pelvic floor exam and hope that you get better, but just know that I care, that's already going to decrease a lot of what you're going through. And I find that telling someone parasympathetic, sympathetic is similar to a lot of these doctors or pelvic floor or even regular therapists that tell people you have inflammation. What does inflammation even mean? Like, where did we get these buzzwords from? I remember when I was going through pelvic floor therapy, I saw an acupuncturist and all good intentions, but he was like, you have inflammation in your pelvic regions. He said it with the Chinese accents, but I'm not going to do that. It was way funny. From Canal Street, like I was like, yeah, this guy's I'm going to get it. Acupuncture was part of my journey and it helped. I was like, what does inflammation mean? Where is the inflammation? Can I see it? Is there a test that I can do? So I'm very careful. But what was your question again?
How do you calm the nervous system, if that's the end goal, with what you do as a physical therapist?
Okay, very simple. So in most cases, let's just take most cases here, we have a hypertonicity problem, okay? And when we have that, if I provide a stimulus that is increasing the state of tone, that is increasing that want to contract, which is if I'm doing a soft tissue mobilization on the lower abdominals, if I'm doing a soft tissue mobilization on the bulbo initio, and then, of course, when I do the internal, but I'm getting you to deep diaphragmatic breathing while I'm doing what you're signaling is to the brain is, hey, there is tension here, but we're not doing anything about it. It's proper retraining. This is no different than someone feeling anxiety and telling themselves, okay, let me feel anxiety. It's not scary. So using both.
Is there an element? I remember when I was taught by a chiropractor that if you squeeze certain areas of the muscle, that's the Golgi or something.
Golgi tendon organs?
Yeah, something like that. I think that if you squeeze it, that calms the muscle because it sends signals to the brain sends a signal back to calm that muscle through the nervous system. Is there any mechanism like that happens where if you, like when you squeeze a trigger point, for example,
So I think he's talking about contract, relax, not active. Yeah, I think he's talking about contract, relax. GTOs, I think, from what I remember, they check this, they're the stretch reflex in the muscle, in the tendon. I'm guessing if you take it to a point where, actually, I don't remember. It's not something I use, but that might be true.
I guess what I'm asking for is what's the mechanism of relaxing the nervous system through a physical therapist point of view when they're doing, and you could get in more detail if you want on what's happening. All right, you got the diagnosis, you figured out that, you know, what's happened, hypertonicity. Then what are you doing? What's
happening on the physiological level?
Yeah, that they're going to get relief from their pelvic dysfunction, pelvic pain.
Well, I think you're really just teaching the body that it's okay to not contract. And with most of these men, they're like doing constant Kegels all day. So at some point, we're just doing the opposite of that.
I see.
what is exactly happening on the physiological level, I'm humble enough to say I'm not sure, but I know it works. I know it works. I can't tell you how many guys, and they've seen other pelvic floor doctors who weren't able to get them better because the way it's normally taught is to do this clock method, where and what I'm talking about is when a practitioner does an internal exam, we're taught initially to do, you're at 1 o'clock, and then move to 4, and then move to 7, and then 9, and then do it again. But it's not really specific, and I don't know if we're actually making a change. And most men actually feel really uncomfortable when we're doing that. And over time, this almost like non-specific way of treating it has been very specific.
I see.
It's been working really well.
Is there a level of uncomfortability that they must go through before they get comfortable? So anytime I think muscle tightness, I think, all right, suck it up for an hour or 2 hours a day because you're going to get better later on. Is there that element of it?
I think what you're referring to is like no pain, no gain.
A degree, yeah.
Yeah, without the pain, but no discomfort, no gain type of thing. I'm not of that mindset. The goal is to give you graded exposure and to teach your body that graded exposure is not bad. I think if this makes any sense, I think why we get into a hypertonic pelvic floor is maybe some men hold tension in their pelvic floors, some men hold tension in their traps. Maybe there was trauma in the area, maybe there was sexual trauma, and I don't mean emotional, which could be a thing as well. But maybe there was some physical trauma to the penis or surrounding areas. And at some point, their pelvic floor needed to tighten up. And that's a learned response. I think we can unlearn that response.
And so again, this is a 35-year-old patient that saw you. We gave you the clinical. What are you doing with them that you're going to help them unlearn that response?
Yeah. So if he comes in and he's incredibly tight and I'm able to decrease some of that tightness by doing soft tissue mobilization, and we've already taught the body how to feel what it feels like to relax. And at some point when I'm doing the internal, that is a stimuli that's not comfortable. And they're able to feel what it feels like when they get up, hopefully. And in time, your subconscious mind and let's call it automatic services in the body take over. And then you don't have as much tone because you were allowed to tap into that. Did I answer your question?
Yeah. Yeah. And so are you massaging their pelvic muscles outside of their body and inside of the body?
The soft tissue mobilization.
Yeah, what does that include? Yeah.
Yeah. So soft tissue mobilization is essentially massage, and we're working on the lower abdominal fascia, buccal fascia that surrounds the base of the penis and the scrotal sac. In most cases, if we get men that come in with testicular pain, we want to see if we can affect the genitofemoral nerve, if there's referral pain to those testicles. And yeah, that's exactly what we're doing.
Pelvic muscles are important for erections. Do you find that they come in, and a lot of these patients do have some ED, that could be probably to some degree psychological because it's just, I feel too uncomfortable there. I'm not even into it. But it could be physiological. Have you found that, all right, I treat this guy with pelvic dysfunction and they say, look, my erections are better?
Yeah, a lot. Now, actually, I was going once a week, me and my staff, or sometimes even more than once a week, we do our clinicals. We'll do hands-on work. We'll try and think outside the box. If we have any hard patients, we'll go through them together. And yesterday, we were actually running through buccal fascia, actually. And buccal fascia runs through the penis, but also is right around the base and then comes around the scrotal sac. And we know that the dorsal artery, nerve, and vein are suspended in buccal fascia.
I see.
And penile rigidity and penile shape is heavily influenced by buccal fascia. And so what we see is this new diagnosis that emerged over COVID, actually. It's called hard flaccid. I don't know if you heard of that.
No, tell me more.
So hard flaccid is what happens. A flaccid penis generally should hang. Some are tighter than others. That's fine. But what we see is a semi-rigid penis in a flaccid position. And sometimes they get this hourglass shape in the middle, something constricting it. And that's almost always buccal fascia being really tight in and around the middle part of the penis. So we actually do penile mobs. Think of it as like a base of the penis skin glide, if you will, and see if we can free up some of that tissue so that the erections can get better. And almost, I would probably say over 90% of our cases do get better. Of course, if there's no issues or cause to the ED.
Correct. Yeah.
But most of our men that we see are 25 to 40.
Yeah.
And so I would say that if we do get an older guy here, and when I say older, it doesn't mean old, it just means over that 45, 50. I tell them this is very much a young man's problem. So you're not old. because that's the first thing they think about.
That's correct. That's correct. Adam, thank you so much. Look, you're the first physical therapist ever on the podcast, and we have over 160 episodes. So I appreciate you and the work you do, and your dedication to male pelvic dysfunction, I think, is very important. And I would love the audience to figure out how to find you if they want to see you as a patient.
Yeah, sure thing. So Pelvis.nyc is our website, and we have many free resources there. You could also schedule a free 15-minute consult just to discuss and see if you're appropriate for what we do. You could contact us at hello@pelvis.nyc, and we're looking forward to hearing from anyone who wants to reach out.
So it's hello at
Pelvis.
Pelvis. That's easy to remember. Also, the number is 929-590-3445. Is that right?
Correct.
Thanks a lot, Adam. Appreciate you and your time spending with us and having a very important discussion around pelvic dysfunction.
Thank you for having me.
My pleasure. Thank you, everyone, for watching or listening this episode. We don't have a lot of prostatitis and male pelvic dysfunction. Honestly, there's not a lot of experts in the field, and not a lot of urologists that want to talk about it or care to talk about it. So people that are non-conventional physicians and experts typically are the best in this field, and I see so much of it, and I love seeing this patient just like Dr. Gvili does. And I think that there is hope out there, and there's opportunities to get better, if not resolve the problem through non-conventional. And again, I'm an integrative doctor. I think conventional therapies work very well for a lot of things. I think most would agree, including urologists, that we don't have a lot going on for prostatitis or pelvic dysfunction. So thanks again. Don't forget to subscribe to the Dr. Gio newsletter, drgio.com, and your 5 stars and likes and comments. I can't tell you how helpful they are. The algorithms work better. People can find this information better, and we can help more people. So thanks again. Much love. I'll talk to you next time. Welcome to the Dr. Gio Prostate Podcast. I am Dr. Gio, your host, and today I have the pleasure of speaking with Dr. Adam Gvili, who is a pelvic floor specialist. How do you treat pelvic floor dysfunction? Men, right? Men with prostatitis. Is prostatitis a real thing? As you might have heard with my previous conversation with Jeanette Potts, expert in the field. There are not too many experts in the field, but we have one today.
Thanks for watching the Dr. Gio Prostate Podcast, where knowledge meets action for a healthier, stronger you. If you found this episode helpful, don't forget to hit like, leave us a comment, and subscribe to our channel. And if you want to take your learning even further, join our exclusive membership community at drgio.com for access to full transcripts, curated resources, and member-only discounts. Your health journey starts with the right information, and we're here to guide you every step of the way. Until next time, stay proactive, stay strong, and live your best life.